So I'm going to discuss what's needed overall, the whole process, in order to implement pharmacogenomics. There's a few things that are required. You have to have analytic validity, which means accurate measurement of the genotypes. You can see how that would be required. You have to be able to measure genotypes accurately. There has to be a clear association between the genotypes and a particular patient phenotype, which is clinical validity. You have to be able to have clinical utility, which essentially in this case means, given the fact that there's an association between the genotype and the patient phenotype, is there anything that you can do about it? If there's nothing that you can do to change, the outcome, the clinical outcome for the patient, it's not very useful. It's not very useful in a clinical setting. And then finally, you need a recommendation about what specifically a physician should do. If they get a test result with that genotype and phenotype, there's been shown the clinical validity, the clinical utility is useful. You can do something. What specifically should be done? So I'm going to discuss each of these individual steps. When it comes to implementing, the clinician is probably not so concerned with analytical validity and even clinical utility. That's going to be an assumption to them that already exists. Otherwise, they wouldn't be dealing with it. So it's not something that really enters their mind per se. But it's very important to understand all those pieces. So I'm going to cover them in this particular segment. So analytical validity is basically how well the test predicts the presence or absence of genetic change, how well it measures the genotypes. That encompasses everything from the collection of the sample, transporting the sample to the lab, the tracking of it, documentation regarding that sample, the prep work on the sample to get the genotypes, the actual analysis itself, and the presenting of the results reporting at the end. All of that goes under the umbrella of analytical validity. When people talk about analytical validity, you'll hear them refer to CLIA. What CLIA is it stands for Clinical Laboratory Improvements Amendment. So it's basically federal regulatory standards that apply to all clinical labs that do testing on humans. It excludes research tests and clinical trials. So those don't have to be CLIA approved. But all diagnostic labs on human samples have to be CLIA approved. CLIA covers the qualifications of the lab itself to perform these experiments and the quality control of the tests within that lab. And the goal is to ensure this analytical validity. So the federal requirements for CLIA require that all these laboratories be certified by their individual state, I believe it's state level, before they can accept human samples for diagnostic testing. CLIA does not cover at all, it doesn't address clinical validity or clinical utility. So it's just looking for how accurately does this test measure the genotypes in this situation when we're talking about pharmacogenomics. So clinical validity, after you can be sure that you are measuring the genotypes accurately, you need to be sure that the variant is related to a particular phenotype. You have to have an accuracy there between the genotype and the predicted phenotype of the patient. Clinical validity includes, under that umbrella, terms such as clinical sensitivity, specificity, positive and negative predictive values. These are all statistical terms that I'm going to describe in a little bit more detail. Statistics like this typically require large sample sizes. On the other hand, pharmacogenomics sample studies are typically small. These studies are typically small because it requires patients to be on a specific medication, and sometimes there's not that many people on a particular medication. Think about like a cancer therapy or what have you. So sometimes there's not a ton of people on the medication. You have to have that, and then you have to have people that also have these specific variants on that medication in order to perform these pharmacogenomic studies. So it's kind of difficult in this case to prove some of this clinical validity with pharmacogenomics studies. So I'm just going to say that up front. So again, these tests are statistically based. It's like a GWAS that's been discussed in other segments where you need really large numbers in order to get statistical power. But we have a little bit of a problem with statistical power in pharmacogenomics. Okay, so clinical validity also depends on the prevalence and the penetrance of the variants that are being studied. So I'm going to describe what specificity and sensitivity are, positive predictive value, negative predictive value. But before we get into that, we have to define a few terms here. True positive. What's a true positive? It is the test result is positive and the patient actually does have that phenotype. That's a true positive. The test says yes, and the patient does have it, so we're all good. A false positive is where the test result is positive, but the patient does not actually have that phenotype. That's a false positive. True negative is the test says no, the test is negative, and it is true that the patient does not have that genotype. That is a true negative. And a false negative is you have a negative test result, but unfortunately the patient does have that phenotype, so that was missed. Okay. They're pretty straightforward, but you have to keep all of these terms in mind whenever you go through this process. So you can put this group, true positive, true negative, false negative, in a grid. Okay? If you make a grid and you have on the left-hand side, you have a positive test result and negative test result, and along the top you have phenotype, non-phenotype, then in these cells, A, B, C, and D, you can group your true positives, your false negatives, and your true negatives. Okay? We're going to refer back to this grid a few times during this discussion. So just wanted to show you the grid up front, and then we're going to talk about sensitivity and specificity. And then I'm going to show you what that looks like on the grid. Okay, sensitivity. How often will a person with the condition have a positive test result? That's what sensitivity is. So it's the ability to correctly identify patients with the phenotype. There's a formula for it. You take your true positives and you divide that by the sum of the true positives and the false negatives. Okay, so we're going to go back to that grid in a second. So sensitivity is how often will a person with the condition have a positive result? Okay. Specificity is more concerned with how often will a person without the condition have a negative test result. This is kind of the opposite corner of this grid, right? So we're looking at this time the true negative rate divided by true negatives and false positives. So if a test is highly sensitive and the test result is negative, okay, so if you have a highly sensitive test, the result is negative, you can be nearly certain that that person does not have that phenotype. A test with 100% sensitivity will always correctly identify the people with the phenotype, okay? So, but if it only has 80% specificity, it will detect 80% of the people with the disease, but it will miss 20% of the people with the disease. So I hope that you follow along with that so far. We're going to put these, I'm going to show you these formulas referring back to the grid. So remember our grid with true positives, false positives, and so forth. Basically, if you set the grid up like this, the sensitivity is just A over A plus C, and specificity is D over B plus D. I'm going to give you an example here, what I'm talking about. Okay, this is a hypothetical example. Let's say we have these numbers. So there are 100,000 people that we looked at total. 90 of them are true positives. 94,905 are true negatives, and so forth. So if we look at the specificity of this test, we're going to take 90 divided by 100. So you're looking at 90% sensitivity in this case, 90% sensitivity. If we're going to look at specificity, we're going to take the 94,905 and divide them by 99,000. This looks at 95% specificity. Seems like a good test, right? I mean, you've got 90% sensitivity and 95% specificity. Okay, looking pretty good. Now we're going to talk about positive and negative predictive values. So positive predictive value answers the question, if the test result is positive, what is the probability that the patient does have that phenotype? Okay, so there's the equation there. You're going to take the true positives, divide them by all the positives, true and false. And then negative predictive value is just the other side of that. If it's negative, what's the probability that the patient does not have that phenotype? Okay, so you can divide it the same way. On the grid, on the grid it looks like this. So the PPV is the positive predictive value, NPV is negative predictive value. You can run the numbers the same. So this test that looked like it had great sensitivity and specificity, if you look at it in this light, you have a great negative predictive value. You're catching almost everybody that you say that the test says doesn't have the phenotype does not have the phenotype. You're great with that, okay? But your positive predictive value is not looking so good. You're at like 1.8% here. And that's because you've got a lot of positive test results, but there's only 90 people who truly are positive in this particular case. So what's happening here is that you're flagging a bunch of people as having a positive test result who aren't really positive. And this happens with really great tests. Tests that are really very sensitive and very specific sometimes have this kind of an issue. What's going on here is that it's the prevalence of the condition in the population is affecting your numbers, okay? Sensitivity and specificity are test dependent. So they really tell you how good the test is at measuring what you have. And they don't pay, those parameters don't pay any attention to the population that you're studying at all. It's only how good is the test. But the positive predictive value and the negative predictive value are population dependent. And they are very influenced by the prevalence. So in the example I showed you, the prevalence of this phenotype in the population is really low. There are only 100 people in 100,000 people who have this particular phenotype. So even though your test is really good at picking up who does and doesn't have the phenotype, because so few people in the population even have that phenotype to begin with, it's giving you a poor PPV. If you were looking at a situation where the numbers are different and you have a much more common condition, it's going to change the scenario. So now instead of only 100 people have 100,000, we've got 5,000 people out of 105,000. So this is a little bit better prevalence of this particular phenotype. In this case, the sensitivity and the specificity of the test are exactly the same, because this is about the test. So you still have 90% sensitivity, 95% specificity, okay? But because there's a lot more people in the population that have this condition, you still got a great negative predictive value, but now you've increased your positive predictive value to almost 50%. You didn't change the test at all. The sensitivity, the specificity haven't changed. But just by virtue of the fact that you now have a larger population with that condition, you're going to change the predictive value of the test. Clinicians and patients are often interested in the positive predictive value and the negative predictive value. They care about the sensitivity and specificity of the test, to be sure, but they're more thinking of things in terms of, if I test positive, do I really have this condition? And if I test negative, do I really not have it? Like, that's kind of like their mindset. They're not thinking of accuracy of the test. So those numbers are really important, and people can be put off by these numbers even though the test may be very good. And this happens in, these are hypothetical numbers, but this is kind of a situation for, say, mammograms and catching breast cancer on mammogram. Because the test is sensitive and specific and has great numbers for that. But because so few of the people tested are ever going to have that particular condition, there's a lot of people who have a positive test result on a mammogram who in the end don't actually have breast cancer, just by virtue of the numbers in the population. It doesn't make it a bad test. It just means that you need additional screening on top of it. It's great as a screening test, but you're going to need other tests in order to determine who truly is a true positive in your population. Okay, that's about clinical validity. Now we're going to talk about clinical utility. Clinical utility can be kind of subjective here. What clinical utility wants to get at is, can the test provide information about the diagnosis, the treatment of the disease, the management of the disease that will be helpful to a patient? Okay? They want to know how likely is it that getting a particular test result will result in a therapy or some kind of treatment to improve the outcome for the patient. They look at, for assessing clinical utility, the CDC recommends asking questions such as, is the intervention effective? Is it available to people? So there might be really effective intervention, but it's not available to the majority of the population. Only a specific few would even have access to an intervention that would improve outcome. They look at, they ask questions such as, what are the economic benefits associated with actions resulting from testing? What facilities are available? Are they easily put into place? What method exists for long-term monitoring of the patients? Questions such as public health versus personalized medicine come into play. So if this is something that's very rare and doesn't affect the majority of people, is the test clinically useful? Like I said, clinical utility can be subjective, and it's kind of a high bar. Some people argue that if a test doesn't address a lot of these questions well, for example, the therapy is not available to a lot of the population, it's not an overall economic benefit to the population as a whole, that the tests are not meeting the burden of clinical utility. Other people will argue that if it benefits even a small group of patients, that there's clinical utility for them, and that's part of personalized medicine. And so they see the clinical utility even if it doesn't pass all of these particular questions. So clinical utility can be debated, and it is debated. And I'm not going to be able to solve that for you today. And you're going to have to think for yourself what you think should be the standards for a test to be termed as meeting clinical utility.